that conference. So I am introducing Professor Sajal Banerjee. Already you have seen Professor Sajal Banerjee already, our president of Heart Failure Society and our ex-chairman of our Bangabandhu Sheikh Medical University. So Professor Sajal Banerjee, are you hearing, sir?
Yes.
Sir, I am
Can you hear me?
Hi.
Yeah, I am interesting with already you have learned known about the provocation. Already has given a proposal, and so actually he's the president of Indian Society for Transplantation, and he has given a proposal. Dr. Kewal Krishan, already I have conveyed your actually message to Professor Sajal Banerjee. He also agreed about your proposal, and we will contact with. I am also joint secretary of the Heart Failure Society also, so I will keep touch with you also.
Yeah, because see, when I need the Southeast Asia should be like, we should be doing something. See, I have been in this field since 2006. I went to Mayo. So for the 14 years, I'm doing this ventricular assist device, heart transplant, and all these things. So ECMO stuff and what. But when I came to this country in 2012-13, it took me 2 years to develop the system. Since 2015, I'm putting this ventricular system. So at this point, I'm probably doing the maximum MCS. And I'm a program committee member of International Society also for MCS. So I think and we should be doing, in this part of the world, we should be active in this area. And trust me, it's not a rocket science. The only thing is you have to come out of bit of your comfort area. You like the surgeons and cardiologists. The cardiologists are more into like Arjuna. I want to put stent into the diagonal. That's it. And the surgeons are more into bypass surgery and valve simple. But this is a very interesting field and it's growing also.
Yes, yes. Yeah. And today's your presentation also very new for cardiologists, though. Yes. You have your presentation, especially from the surgical point of view. But I think
I'm taking care of cardiology part also.
Because,
more of the cardiologist part.
Yeah,
so
I know.
It will and not much of the OT stuff. I'm not sure. So.
Already in Bangladesh, cardiac surgeon also joined with not only cardiologist, because that will be very good discussion, because our few cardiac surgeon also will join the chairperson and panelist. So that, I hope this will be a wonderful session. And our Mishkat Chaudhary already you have discussed. He's a very learned person in Bangladesh also, especially in cardiological in our cardiological arena. So he's very talented people, and already Professor Zaman, I think Dr. Praveen Chandra, Dr. Aliul Islam already joining, Lutfur Rahman, Professor Dr. Shams Munwar, Dr. C.M. Shahin Kabir, Dr. Dipal Chaudhary. I hope Dr. Dipal Chaudhary, Dipal Kumar Adhikari, which time I want to start actually, we'll moderate the session.
I can start now because we are to.
Professor Sorabajan also joined, and
we are waiting for our another speaker, Dr. Praveen Chandra.
No, he will join later because he's now already we contact with him. He's on the after the call Kewal Krishan session. He will join. I have keep in touch with him.
Okay, sir. Thank you.
He's in another session. So I think if our chairpersons now the senior chairpersons who is with the permission of the chairperson will proceed on.
Is Subhe madam there?
Madam,
no, sir. Madam will not.
Madam bolchilo amake. Madam will told me evening he will join. She will join.
So last time I talked to her, she also said that he will join. She will join.
Dipal to একবার try করে দেখেন আর সরল স্যার আছে তো সরল স্যার থাকলে হবে আমার মনে হয় সরল স্যার
আমি আজকে আমার মোবাইল দিয়ে করতে হচ্ছে তো আমি আর পারবো না
আমি করছি আমার I think Professor Sajal Banerjee is senior person.
Yes, you can start. Possibly Possibly you can start because the time is really
Exactly.
the right time.
Exactly, sir.
Before that, Zaman, will you introduce Sir, Professor Shadul Banerjee, Sir? Because
Okay.
we need to introduce Sir as a president of Bangladesh Society of Heart Failure.
Shadul Banerjee, actually legendary professor in our country. He's a very senior professor, and he was actually now the president of Bangladesh Heart Failure Association, and ex-chairman of Cardiology Department, Bangabandhu Sheikh Mujib Medical University, our only one medical university. He was vice president of Bangladesh Cardiac Society, and lot of platform he has actually. And not only this position, he's actually just like our father in the interventional or not only clinical, as a whole cardiology. So even cardiac surgeon, everybody actually obeys him, and we are still now his student also. Understand? Not now, though I am now professor, but I am direct student of Professor Shadul Banerjee, and a lot of other chairperson, Professor Shams Manohar, Professor. I am saying watching that Prabhu Zaman. They are also very senior teacher, and our good interventional cardiologist, and Professor Dr. Walid Islam and other Dr. Dipal Dikaria, you can start actually. Then we can actually, according to systematic, we can go.
I'm talk to Madam. Madam will join within 5 minutes.
Then can we wait for another 5 minutes?
Dr. Praveen Chandra already, our renowned cardiac surgeon. Thank you for joining. And Shams Manohar.
Can I talk with Professor Kewal?
Yes, sir.
Yeah.
Yes, sir.
Yeah.
I rather want you to speak with him because he's interested in supporting us in different respects.
Okay.
How we can develop in heart failure clinic.
Yeah. Very nice. We will be rather happy if we can work together.
Yeah.
We want support from him.
Yeah.
We want to work together.
Yeah.
It is a great privilege and honor for me to say some few words, particularly mentioning you. You will be a really helping person for us, and a really resource person for our Heart Failure Association, and we want your wholehearted support. And I will be rather happy and privileged as well as honored if you extend your hands for our association in future. So I will request you to do everything, and we will work heart to heart, and the bondage will be a big one, so that we can work together. This is my earnest request, and I hope that you will accept our this earnest request, and my desire is that we will work together.
Okay, for sure. See, what we can do is we can have a Zoom meeting 1 week or 2 weeks down the line to discuss how you can proceed further, because we have made this heart and lung transplant in India in 2017. It has progressed to the level that now a lot of people, almost most of the people, cardiac surgeons and cardiologists, those who are interested in heart failure, they are part of this. And like we used to do from 11 to 15 or 16, we used to do like 10, 15 or 20 cases of transplant LVAD, and now almost 100 cases of heart transplant, almost 100 of lung, and 20 to 30 of ventricular assist device we are putting in India. So I think this will encourage you to get all the experience in this part of the world with similar kind of patient population. Yeah, that will be a great to understand, because in America, I'm also part of that society, international society, MCS, the Mechanical Circulatory Support and Program. But the issue system and different kind of others. But Bangladesh is more or less like the population which the most of the physicians same kind of problem which the Indian doctors they feel in the beginning. Later on, when everything is established, then anybody can do it. Then even it's simple. But in the beginning, you have to be really withstanding all the problems.
Right.
To
Absolutely.
I
take
think
the
we can
things
start
to next
our
level.
session. Otherwise,
And then,
another renowned cardiac surgeon, Dr. Lutfur Rahman, also joined. So I think we can start very soon because otherwise, we can make the time. So,
yeah, time
Professor
will be.
Dr. Deepal, you can start with the permission of the chair.
Okay.
Before starting the
Adnan?
program, sir, before starting the program, I'm requesting everyone that we will make this program Facebook Live. So we need 2 minutes to going Facebook Live. Sir, shall I start for the Facebook Live?
Yes,
Yeah.
yes.
Thank you so much, sir. Thank you so much. We are now on Facebook Live.
Thank you, Professor Deepal. The moderator, you can start, please.
So,
Can I have the screen, Adnan?
I'm great.
Dr. Kishan, before starting, actually, our moderator will officially
not a
will
problem.
start this.
Okay, not a problem. Thank you.
Can I have the screen?
Yes, yes, yes.
Adnan?
Yes, yes, you can proceed, please.
You can proceed, sir. We are now on screen.
A very, very good evening, honorable chairpersons, respected panelists and speakers and learned audience. I, Dr. Kewal Krishan Adhikari, welcoming all of you to this evening's webinar jointly organized by the Department of Cardiology, PSMO, and Bangladesh Cardiovascular Research Foundation, with the technical support from the Incepta Pharmaceuticals Limited. Today, we will have with us two eminent speakers from India, from whom we will learn a lot. I feel very much delighted to introduce Professor Emeritus Sufyar Rahman, Professor Syed Ali Hassan, Professor Sajul Krishna Banerjee, Dr. APM Sarabujjaman, Dr. NAM Mominujjaman, Professor Chaudhry Mishkat Ahmed, Professor Harisul Haq, Professor Farooq Ahmed, Dr. Lutfur Rahman as chairpersons, and Professor Dr. A.S.M. Waliul Islam, Dr. Prashant Kumar Chanda, Dr. C.M. Shahin Kabir, and Dr. Ashraful Islam as panelists. Now, as usual, for welcome address, I will request Professor S.M. Mustafa Zaman, the President of CVRA Bangladesh, to say a few words. Professor Zaman, please.
Thank you, Dr. Deepal Krishna Adhikari, for your nice starting. And already you have discussed many things, and this is our regular actual webinar. And already Professor Sufyar Rahman, another our mentor, already joined in this session, and we are very actually honored for her joining. And already our renowned and senior interventional cardiologist and cardiac surgeon all are already joined. And I think it would be an interesting session. And we have learned many things, especially from Dr. Kewal Krishan and another speaker, Dr. Praveen Chandra, is also very renowned in our country also. So I'll now extend my actually space, and I'd request Dr. Dipal Krishna Adhikari, please give some few introduction with Dr. Kewal Krishan, and then we start the session. Dr. Dipal Krishna Adhikari, are you hearing?
Okay. Now I have the privilege to introduce in front of you a legendary cardiac surgeon, Dr. Kewal Krishan, who had his MBBS, MS, MCH, and DNB from India, then moved to renowned Mayo Clinic and Mount Sinai Hospital in USA for advanced fellowship program. He is currently the director of heart transplant and ventricular assist device, Max Heart and Vascular Institute, Saket, New Delhi. And now is the president of Indian Society of Heart and Lung Transplantation, working as visiting professor and co-principal investigator LVAD, IIT Kharagpur, and is a visiting consultant of heart and lung transplantation, LVAD and ECMO, Nanavati Hospital, Mumbai. He will be talking on mechanical support for mechanical complications of acute MI. May I request Dr. Kewal Krishan with his deliberation.
So, thank you very much for the introduction. And today I'm going to speak on mechanical circulatory support helping in mechanical complications of acute MI. So most of the cardiologists, they are dealing with acute MI, treating them with PCIs, multi-vessel PCI, single vessel PCI to save lives. But sometimes the heart function goes way down that you need some help in the big for some time. So, or for permanently. If the ejection fraction goes way down for permanent, complete. So these kind of patient, they need some kind of support. Some you must be using like IABP, but other supports, which I'm going to talk today and give a throwing light on what is required by cardiologists in a complicated patients. So before 2013, the heart failure, the concept was way different than what we are doing nowadays. Before 2013, most of the heart failure patients were treated with the horse with Lanoxib, or unload the horse with Lasix, or slow the horse with beta blockers. But now the treatments are different and they are more effective and permanent solutions. One is get the new horse, means do a heart transplant, or get a new tractor, means put a ventricular assist device, or heal the horse with mitral clip or other conventional procedures like PCI or mitral valve repair or CABG or any other procedure which can make the things better from the present situation. So you all cardiologists and surgeons, they are well aware of balloon pump, and balloon pump support 15% of the cardiac output. That's I'm talking of linear balloon pump. The new balloon pump, mega balloon pump, which I'm going to show in next few slides, that has improved to 20%, 25%. Circulatory support given by Impella or tandem heart is 30 to 60%, and nowadays being used in India almost like 20 to 30 a month in India, the consumption is. Levitronics or CentriMag, which I'm going to show in my slides, are HeartMate 2-3, they are permanent devices. They support 100% of the circulatory support. And ECMO is another, supports 100%, but if the lung support is also required, like patient is in pulmonary edema, but that is an extracorporeal support. You can put it for some time and then remove it once the patient recovers. So the mechanical complication, which is the talk of the today, the most common mechanical complications are either mitral regurgitation post-MI or ventricular septal rupture post-MI or LV aneurysm post-MI. So why the MR happens when the ventricle, it's infarct happens, the ventricle gets dilated or acute dilatation because it cannot pump blood forward. So because the papillary muscles, they get separated, there is some space in the mitral valve, and that causes mitral regurgitation. If you see there are patients, those post-MI, they develop mitral regurgitation. Mild MR is very common, and most of the cardiologists come across this. Sometimes moderate and sometimes severe MR, maybe because of the ruptured papillary muscle or maybe because of the dilatation of the ventricle. Another problem which happens is post-MI VSD. Believe me, the post-MI VSD used to be death, because a lot of the surgeons, they operate and the patient doesn't make it. Now, with the help of ECMO, we have, in the last 4 post-MI VSD, they went home, just because we could use mechanical circulatory supports to help these post-MI VSDs. Because what happens when the myocardial infarct happens, in the first week, the ventricle starts getting dilated, and by 3 months, it forms a big size ventricular aneurysm. The size of the LV cavity increases because of the this Laplace equation. The wall tension increases with that when the ventricular cavity size is. The workload of the left ventricle increases, and that keeps on increasing the size of left ventricle and leads to ejection fraction from 50, 60 to 20% or 30%. Because this kind, in the beginning, it's a dyskinetic segment, and later on becomes an akinetic segment. In the beginning, echo looks like this, and later on looks like this. And if these patients, they sustain MI, like the patient in Kazakhstan or CSI, other countries, they get MI, they develop MI, and they sustain that MI, and after 5-10 years, you see this aneurysm gets calcified and looks like this when the patient comes to us after the second MI or some other reasons. When we operate, we find this kind of, and then when we cut it like this, you can see the calcium, like almost whole of the left ventricular wall, anterior wall, we have cut it and then sutured it, and the patient went home. Another is the acute MI develops and ventricular wall rupture, and I would say it's an impending rupture when we open the pericardium and the blood started coming out of it. So this is another kind of acute rupture of the ventricle. In such kind of patient, either we use balloon pump, which is a most common practice for the last 20-30 years. When the patient has a poor LV function, you are going to do either PCI or you're going to do a surgery. You need to put a balloon pump, that linear balloon pump, which we usually put 40 cc. They support, as I mentioned in my previous slide, they support only 15 to 20%. The mega balloon supports 20 to 25% because it's a larger size, displays more volume, and the size is big. Recently, in the last 1 year, the MACA has introduced this, and it looks like promising in difficult situations. But you don't have the access to tandem heart impella. It gives a little more, it's not way more, but little more support. Another thing, tandem heart, which was I've used it 3-4 times with this Mount Sinai people, they use it a lot for multi-vessel PCI or complex PCI. Those kind of situation, you put a patient on tandem heart and then do the PCI and then remove next day this balloon, this tandem heart. Another impella, as I mentioned, now in India, it used to be only 1 or 2 in a year, and now it's almost 20 impellas are being used a month across the country. So impella 5 is used by the surgeon, but impella 2.5, which gives partial support, that is being used by cardiologists. And it's being used in all the big centers. The right impella is also being used. That is when the patient has a right ventricular MI, because most of the people, they know that the large infarct of right ventricle leads to death. So if the patient already has one impella on the left side, or there's no impella on the right, the left ventricle is working, but in the right side, you can put the impella and then give the right ventricle enough time for the right ventricle to recover. And this will increase the circulation and increase the cardiac output, and then patient can be benefited from that. We can save the life of these patients. Sometimes when the patient comes to you, the patient are, along with MI, they already have pulmonary edema. Then you need to support them with the lung support also, because gross pulmonary edema with heart failure, right or left, it gives a like a very grave picture and to save the patient. So we put the patient on ECMO in such kind of patient, and the ECMO, the regular ECMO cost a lot. Like in India, it costs 3.5 to 4 lakhs, but we have got this ECMO that is only 90,000 or 1 lakh rupees in Indian currency. So, and that can be used for 8 to 10 hours. You can put the ECMO, do the PCI, and then remove the ECMO in the cath lab, or when the patient goes in ICU to support it for sometimes. The indication to putting the ECMO is cardiac, respiratory, and cardiorespiratory. As I mentioned, all this short-term devices, they are being used either as multi-vessel or large infarct PCI, or you when the balloon pump does not work, then you can put the patient on this or any kind of ECMO. It could be, most of the time it's VA ECMO when you require it to be put. So, and or Veno-Venous we usually used for only for pulmonary edema or for other problems. This is the way we do the cannulation. You can do surgical, or in the cath lab you can do percutaneous also. Put an artery into the femoral artery, and put a cannula antegrade also into the artery, because when you put the bigger cannula up, there's no space left. And the bypass surgery, when we do any surgery through the groin, it's only 5-6 hours. But when you're going to put ECMO, it's going to may stay 2 days, 4 days, 5 days. You don't want the limb to get compromised. So we put a 5 French or 7 French sheath antegrade, so that the flow will keep on going to the limb. And venous cannula, usually 25 multi-stage or 28 cannula we put it, and drain the blood, and that is how most of the patient it works. And this is how the X-ray looks like. In this, venous cannula is going into RA, and the arterial cannula is into the groin. Venous ECMO we usually put from groin and the SVC. And these are the cannula. The Mackay cannula, which has come as 17. We in the like last 4 or 5 years, we had a bigger cannula as 21 or 23. We used to put a femoral, and that had some vascular issues. But with a new cannula which has introduced by Mackay in the last 1 year with 17 French, we get a 5 liter of flow, and that is enough for the patient. And 25 of multi-stage venous cannula. And this is how they look like. And when you put this, the patient becomes stable, everything. Another way you can do it is the carotid cannulation, but it used to be done, but now risk of stroke is there because you are putting cannula into the carotid artery. So you don't want the risk. And if the patient require dialysis, because most of the patient, when they are very sick, they are sick for like 6 hours, 8 hours before the intervention, and the kidney function go down, you can do dialysis. You don't have to put extra cannula to the body. You can do dialysis from the ECMO circuit also. This patient had MI, and after 2 days he has again another MI, and his ejection fraction dropped to 10%. We put the patient on ECMO, and balloon pump was already there, and then we shifted the patient to our center in the ambulance, and then brought to our center. I'll show you what we did later on. Another device which is CentriMag, it's a wonderful device to save many patients. The only thing is it's a bit costlier than ECMO Mackay system, but it gives very good results. Whether it's a right ventricular failure, or left ventricular failure, or patient with viral myocarditis or something like that. So it can be used it's a very versatile, lightweight, and centrifugal pump. Actually, the concept is so good that the HeartMate people, they have bought this device and used this concept to make a HeartMate 3 as upside down. So, and this is how it works. This less blood damage, very biocompatible, and not bilirubin does not raise with this. So it can be used as a RVAD, or as a LVAD, or as a BiVAD. And if you see the monitor, the red one is LVAD and the blue is RVAD, and you can use it as a anyway. This is how it looks like on the bedside of the patient. And because these short-term devices, they can be either used as bridge to recovery. Means the patient has come in acute failure, you put that, whether Centrimag or ECMO or impeller, you put it and now patient got better, like viral myocarditis. You treat the patient and then remove it. That is a bridge to recovery. Bridge to decision is when we put these patients. Sometimes the blood pressure is 60, your lactate is 18, and you don't know this patient's going to make it or not. So you put a short-term devices, which I have already mentioned all them, because short-term devices are way cheaper. They are less than 5 lakhs, everything other than impeller. And these can be put immediately within 20 to 30 minutes. And then you can, if the patient makes it, then you can decide what to be done next, because the permanent ventricular assist devices are too costly, like 90 lakhs or so. So either you can use as a bridge to, if the patient does not recover, you can use as a bridge to another device, or you can use it as a bridge to heart transplant. So decision is more important than the incision, because it's everywhere. Does the patient has potential reversibility with the pulmonary cardiac or cardiopulmonary? And another part is the conventional treatment will gain anything? Because when the patient is sent to you, then most of the time they are dying, basically. They're dead. So it's better to refer them early than too late. Then even if you put it, does not make much difference. The patient has to be sufficiently sick to warrant the extracorporeal support, because this is a major undertaking, and you have put a lot of ECMO or a lot of Centrimag does not mean you are going to put it. If you have nail, everything, if you have hammer, everything looks nail, should not be like that. So patient has to be sufficiently sick to go for, because the devices, all these tests, they have some complication also, because you can do a vascular complication during putting that. You might have some another issue. So it's better to put in a sick patients than using. And the neurological status has to be good. I'll share one experience. One patient agreed to go for ECMO at 9 a.m. in the morning, and then we thought now we are going to put it. We checked the neurological status, everything, and later on, patient said, "Oh, we don't have money." So they waited for some time. In 9 p.m. they agreed, and at 11 o'clock we came and put the device without seeing the neurological status. Meanwhile, from 9 a.m. to 9 p.m., his saturation remained low, his blood pressure remained low, and patient became brain dead. But we put it in one patient. That is why if you have, which all the face. So you need to check again if the time is more than 6 hours. So, and if the heparin limitation is there, then you need to be very careful about that. So these short-term devices are rescue therapy, and they are meant to be put in a dying patient. Not that. That means patient's blood pressure is 40, 50, and has no urine, and lactate is too much. You know this patient is going to die anyway, so there's no point in putting that. So key to success for the short-term MCS may be the time of initiation. So now, if the patient does not recover from ventricular this infarct, and ejection fraction is 15%, 20%, patient is stable. Now you need to do something for that. Otherwise, this size of the heart will keep on getting increased. Patient will go in sudden cardiac death because of ventricular fibrillation, or something else happens. Or patient develops clot in the stagnant ventricle, and then stroke happens. So you need to go for next level, either heart transplant or ventricular assist device. And we have now a number of ventricular assist device, most commonly HeartMate 2, 3, and HeartWare. So inflow cannula into the ventricle pump, and the outflow graft and driveline which comes out of the body. I am going to show you at this HeartMate 3 that the centrifugal pump, when you put the pump into the left ventricular apex, and it takes the blood from the left ventricle and gives to the aorta. Yes, most of the function of the left ventricle is taken by the device. So it's the cardiac output increases, and the patient becomes normal clinically. So this is how the centrifugal pump works. It's very small, compact, and it has shown very good results so far. HeartMate 3 or hardware is a similar kind of pump, and it helps a lot. Both the pumps are good. If the patient has a biventricular failure, then you can either go for paracorporeal devices, way cheaper, but hardware BiVAD is the most commonly used BiVAD. HeartMate 6, which I have written, is because of the 2 HeartMate 3s are there in one of patients. So, or Syncardia total artificial heart. I'm a registered surgeon for Asia and Middle East for Syncardia. Only surgeon registered for Syncardia to do that. So we have a lot of patients, those I'm going to show you, because a lot of people have in mind, oh, after LVAD, they remain like sick patient, or most of the patients, they are doing fine. And which we did in 2015, they have completed 5 years, and next set, another is coming, they will also complete next year, 5 years. So the guy from this 2015 we put in, and he had, because HeartMate 2 works for 3 to 7 years, HeartMate 3 works 13 to 15 years. That is expected. So, and this patient had a bridge to recovery after 22 months of LVAD. And they enjoy on LVAD. This guy has completed more than 5 years. In October, he will be completing 6 years almost. And this lady, she has completed 5 years this 5th of August. And this man is 71-year-old on the corner with the bag. So he's also completed 5 years on LVAD. Excellent quality of life. And this guy, Ali Salman from Iraq, I asked him to walk and he started dancing in the corridor on day 12 of surgery. He had 1 wife and now he has 3. So you can imagine how much quality of life improves after this. Mr. Akbas is a 56-year-old from Kazakhstan, and he's a mechanic in auto industry. So he's doing fine. This lady is a 81-year-old. You should, the next 2 slides are very important, because for heart transplant, we usually say after the age of 65, we usually don't do heart transplant because immunosuppression put an impact on the existing renal function. But for LVAD, you have no limitation such kind of. We have put 2 patients on the octogenarians above the age of 80. The maximum, the oldest age which is put is 89-year-old. She's completed 3 years on LVAD. So 81-year-old and another girl which is a 7-year-old, and I'm going to show you her. After 1 month of surgery, she was in her own country and with a bag in the back. So you can see how she's the youngest kid of Asia Pacific on LVAD. The guy which I mentioned that he had 2 wives, now he sent 1 more guy from Iraq. The indication was he wants to get married. His ejection fraction is 20% for last 10 years. Now we put the VAD in January, and now he went to his home country in February. The guy which I mentioned in the beginning, that 46 with the 1 MI and then 2 MI, and then we shifted the patient to our hospital. He was on 22 days on VA ECMO, and we tried to wean 3 times. We failed to wean it because the heart function was 10% and didn't improve. So we put a patient HeartMate 3 and sent home in March, just before lockdown. The another guy implanted hardware March 20 this year. The only thing you require for this is INR 2.5, which most of the physicians and surgeons keep for their mechanical valve patients. A lot of people ask me the difference between LVADs and transplants. After the age of 65, we usually don't do heart transplant, and LVAD can be done at any age. High pulmonary vascular resistance, when the patient has a PVR of more than 6 Woods units, we usually don't do heart transplant. Now, actually, the indication for putting LVAD is another, that bridge to candidacy. Even if the patient wants heart transplant, you put the VAD within 18 months to 2 years, the PVR comes down to normal, you can do LVAD. Even with the, we do, and another thing which we do is we home milrinone on home vitamin therapy we give for 4 to 6 months. The patient is on pump at home with the vitamin milrinone for 4 to 6 months, and PVR has come down from 4.5 to 2.5. So This is another way to do it. High susceptibility to infection, like those patients have more chances of tuberculosis with immunosuppression or chances of rejection, the high PRA, then you can do a LVAD. And overweight patient, like the patient has 120 kg, you will not find a similar kind of donor in that. So ventricular assist device is another option. And another advantage of LVAD is we can do in 3 days. You don't have to be waiting on the list for heart transplant. The mechanical complications, if it has biventricular failure and you don't have finances for, sorry. Oh, sorry. Sorry.
Hello.
Then you can go for transplant, and for more information, you can go to my website, kewalkrishan.com.
Thank you.
Thank you. Thank you, Dr. Kewal Krishan, for your excellent deliberation. This was very high-tech, but it was just very simple to us for your kind and excellent deliberation. I congratulate you from my core of the heart. Thank you very much. Now I request Professor S.M. Mustafa Zaman to introduce our next speaker, Dr. Praveen Chandra.
Thank you, Dr. Dept Krishna. Already a lot of senior cardiologists and surgeons with us, and they are also with us a lot of time. And Dr. Praveen Chandra has joined with me, the next speaker. Actually, everybody knows about Dr. Praveen Chandra. So I have a relationship with emotional because I did my fellowship in Max Hospital, and he was my mentor. And so it is my pleasure to introduce him. And Dr. Praveen Chandra is a leading Indian cardiologist and the chairman of now interventional cardiology at Medanta Medicity, Gurgaon, India. And he is recognized one of the leaders in angioplasty in the world now. And he has been awarded for success and achievement in the field of cardiology as Padma Shri in 2016 by the President of India. And he has also served as Director of Cardiac Cath Lab and Acute MI Service at Max Hospitals and a lot of hospitals in India also. And he is renowned, and his expertise in the field of cardiology, everybody knows. And so because not only in the acute MI, he is a leader of the in TAVI in India also, and abdominal aortic aneurysm, and other field of interventional cardiology also. So it's our privilege that our next speakers will even especially in tips and tricks of acute MI and primary PCI. And it is my pleasure. Again, I mentioned that is my I get not only knowledge from him, but love and affection also during my stay in Delhi, lot of time with him. So I am really grateful. Again, it's a privilege. So I request Dr. Praveen Chandra, please proceed and on tips and tricks of primary PCI.
Thank you, Dr. Mustafa Zaman and all my friends from Bangladesh. It is a pleasure to share all this information and knowledge, which is now increasing every day, and we have to keep abreast with the new things. So whatever best I can do, I will try to do, and of course we learn from each other, and I will try to finish my presentation in time so that we can have some time for discussion. So I know that a lot of intervention is being done today in Bangladesh, and very high quality intervention is being done in Bangladesh today. And I'm proud to see that a lot of interventional cardiologists who have been in India for training and visiting are really doing very well. So congratulations to all of you, first of all. And now it is my task today to discuss with you the tips and tricks of primary angioplasty, which is, of course, everybody knows that primary angioplasty is the mainstay of treatment and is the only intervention which has been found to be decreasing mortality and improving survival in patients who undergo angioplasty. In stable angina, the results have not been so good, as you already know. So we have to do this procedures very well, and all kind of patients come to us. Very sick patients, very unstable patients, low ejection fraction, and all kind of things. So I'll take you through cases. My presentation will be through the cases which we have done, and through these examples, I will share with you the information. So what are the issues in primary angioplasty? First, of course, the issue is femoral versus radial. Now it is very clear that as much as possible, we should do the radial axis because the data on radial axis is very positive. It reduces the complications of peripheral, these bleeding complications and femoral axis complications. So radial axis is the preferred axis. Then, of course, the issue of multi-vessel disease, whether we should do all the vessels at the same time or not. So we have now 4 trials which are already there. The primary trial, the culprit trial, and now the FFR guided multi-vessel disease intervention, the complete trial, which was presented in September of 2019. So which says that, we can do FFR guided complete intervention, which is one of the very good ways of addressing this problem of multi-vessel disease and acute MI. Now, the next thing is the presence of a large thrombus, which is again an issue because sometimes the thrombus is medium size, small, and at times it is very, very big. And especially in Indian patients and Bangladeshi patients, young patients, we see a lot of big thrombus because they come little late to us and they are young patients with less disease and more thrombus. So how to address that? Then post-bypass patients come to us with acute MI. So how to address whenever there is a occlusion of the vein grafts, how to deal with the vein grafts, that I'm going to share with you. And the data on this is that, you should try to open the native vessel, but if the native vessel is not possible, then vein graft, can they be opened or not? And how do we open? I am going to share with you. Then, of course, the patients of cardiogenic shock in acute MI, how and when to use ECMO and mechanical assist devices like Impella in these patients. That is something very, very important, and more patients of cardiogenic shock the survival can be improved. And now we have the National Cardiogenic Shock Initiative, which has just been presented in 1 month back in US, and from Dr. From the Detroit Heart Center, and shows that the mortality can be reduced to 40% from 90%. Then, of course, thrombosuction, whether we should do it or not. The data is very, very clear that routine thrombosuction is not advisable, not to be done. Only if there is a dire need or, the thrombus burden is too big, or if there is a distal embolization of thrombus, you can do thrombosuction. Otherwise, routine usage is not recommended. Then how to deal with late presentation, because this is a problem for our countries like India and Bangladesh. It is not in the trials. The late presentation is something which is very important. And so do we do primary angioplasty on them or not? That is another question. So those patients who come to us beyond 12 hours or 24 hours, if there is no post-MI angina or cardiogenic shock, these patients can be assessed non-invasively for further intervention. And then, of course, the use of FFR, OCT, and IVUS in these patients. So let me take you through those cases. Now, this is a case. You can see this is a young patient, 30 years old, comes with acute anterior wall MI, and he's on the table like this. What will you do? So you can see that the main problem here is thrombus. And the thrombus is occluding this artery. There is no place to even put a stent. And if we put a stent, there is a chance that the thrombus will go down, and maybe the thrombus gets squeezed into the left circumflex. So how do we deal with this situation? Now we had this discussion with the colleagues that what should be done, and then we decided that let us do one thing, that give him intracoronary thrombolysis. Okay, because putting a stent here is not a great idea because thrombus burden is too high. You can see suddenly the patient occluded on the table, and then we had to immediately rush and put a wire there. As you can see that the flow is not happening, almost very, very low. So we immediately put a wire, gave intracoronary thrombolytic, and did some gentle dilatation so that some flow is maintained, because you have to maintain some flow. So some flow was maintained. As you can see, there's some flow is happening, but there's slow flow. So we waited for about half an hour. Still the flow is not improving too much after thrombolysis, intracoronary half dose TPA. But you can see that the thrombus burden is decreasing already. You can see that the thrombus burden has decreased a lot. And then we decided to put a stent because the flow was still not TME3. But at least what it did was that you can see that we got a space, the thrombus is gone from the ostium, and then we could easily put a stent from nearly the ostium into going into the LAD. So this is the way we handle large thrombus burden. First, you do pharmacological intervention, and then you put a stent if required. Sometimes we have seen that the thrombus dissolves completely, or maybe just 10% remains, then there is no need to put a stent. So we decided initially not to put a stent, but we had to put because the flow was not improving that much. So after this, the patient was then shifted back, but we see that one of the septals got occluded. So we opened the septal also, and then that was the end of the case. So patient is doing very fine with this kind of approach. So in large thrombus burden, this is our approach. And here you see that we did not even use thrombosuction, because we know that we cannot take out the thrombus. It will only go deep inside, and that will be a more problem. So we gave pharmacological treatment, we gave stent because the flow was not good enough. Another case of a post-bypass patient. So in post-bypass patient, this patient comes to us with acute coronary syndrome, and suddenly his ST elevation happens, and he comes to the cath lab, and where we check, his left system is completely gone, and his vein graft is also completely gone. What do you do in this? Although the approach is that in these kind of cases we should do the native first, but here you can see you cannot approach this native because it is a very badly diffusely diseased artery. So here we see that it is totally blocked, and also we know that in total occlusion of the grafts, it is not a good idea to do angioplasty. But this is acute occlusion, so we thought, let us check if we can get a good access and get a good flow. We will try and do that. So what we do is we immediately move to a guiding catheter, take some shots in different views, but we still do not see anything but except rat tailing of this graft. And this graft is almost going. So we immediately put a wire, and as we put a wire, we see that the flow is happening, but there is a large thrombus here. So we do a gentle ballooning here because there is a chance that it can go inside. And generally we put a distal protection, but there is no place to put a distal protection in this patient. But fortunately, we start getting very good flow, as you can see here. So we put a stent into the distal part of this graft, which is at the junction of this insertion site, and we got a very good flow. And you can see that with the stent, such a huge territory of the heart is completely revascularized. And then this patient, you can see in other views, looks very good. So in vein grafts, we have to be gentle, and sometimes the thrombus burden is too high, so we have to give some intracoronary, apseximab sometimes, or maybe tirofiban, and then of course. But in this patient, we didn't have to give any because he came very early, so the thrombus burden was immediately dealt with just stent implantation. So this can be done. Now, sometimes the patient may not be so stable. So what do we do in this? This is a patient who had a bypass surgery done in June 2018, and then he comes just in few months later, admitted with in February 2019 with chest heaviness, angina, EF 25%. So what we do, we get this patient, put him on a balloon pump, and then do a angiographic evaluation. When we do angio, what we find? Here you see that the RCA is diffusely diseased. The left main is very tight. There is a disease in the proximal LAD, and the circumflex is also quite badly diseased. So, but he has grafts, but when we check for grafts, all the grafts are blocked. There is no graft flow, and he is a patient who is already very sick. So we bring him to the cath lab. We take out the balloon pump and put him on an impella, because if we do have to do any intervention, he needs mechanical circulatory support, MCS. So you see, the impella catheter is being taken inside the left ventricle, and once this positioning is done, as you can see here on this wire is a 018 wire, and the impella is now catheter is positioned properly and starts functioning immediately. So once that functions, then we start doing the intervention on this patient, and we have to open the left main. We have to open the as much as possible the LAD and the circumflex. So we put 2 wires, and multiple dilatations are being done. And here you see, as soon as we dilate the balloon, the pulsatility of the blood goes away, and then as soon as we deflate, it again comes back. So that is the support which we get during the inflation of the balloon. Otherwise, this patient can crash on the table. So we keep doing the intervention with high pressure balloons. It's a very calcified vessel, and do some good inflations. And you can see this is the difference. The pulsatility in aortic pressure, and then when we inflate the balloon in the left main, suddenly everything starts going down. But the impella keeps maintaining the mean pressures. Mean pressures are maintained by impella. So the impella is continuing, and we are doing the intervention from the left main into the circumflex, and we do a kissing balloon inflation, do a left main to LAD stenting, circumflex stenting, and then we got a good result from both the left main to LAD and to the circumflex. And this patient improved after that. The impella was removed, and the procedure was successful. As you can see, this is the final result. So we were very happy. The patient went home. After a few months, again he came with angina. In a few months later, he comes with angina, low ejection fraction, and low BP. So when we bring him to the cath lab to check what's happened, we see that there is a tight stenosis in the left main segment. Then we immediately open it up. On the balloon pump he is, and this time it was simple because we have to just put 1 stent in the instant stenosis segment, and immediately the patient improved, and he was sent home again, and he is doing very well with that. So basically, in cardiogenic shock, in primary PCI, we have to take the help of mechanical circulatory assist devices like a balloon pump, like impella, and also ECMO. I will show you. And at times, the patients may be having very diseased vessels. This is the patient who comes to the cath lab. RCA is occluded. LAD is also very badly diseased. What do we do? So obviously, 90% times we put in a balloon pump in these patients because they need some support, and then do a dilatation of the main vessel, which is the LAD. So don't worry about the RCA in this case. Open one last vessel, and this patient will survive. So this is a very important thing. That opening up of the last remaining vessel was very important, and the patient did improve after this, after these serial dilatations and stents. We have to do a quick job. You can't be too long in this. And once the stents are in position, the blood flow, you can see how much the blood flow is improved soon after this. And once that improves, his balloon is then next day taken out, and he is fine. So in the last remaining vessel, we have to be very quick. We need a support. We have to use the support in primary PCI. Sometimes it is not very clear what has to be done. So in this patient, you can see that this patient comes with acute anterior wall MI. We put in a wire. The wire is being positioned here. And after we put the wire, what we see, that the lesion is not there that much, only thrombus. So we do a OCT to find out if there is a ulcerated lesion or not. And OCT shows that there is an ulcerated lesion, and then we stent it directly. There is no need to do a ballooning. So we do a stent implantation, and we got a good result in this case. Soon after that, and then post dilatation is done to get a good result. So OCT, pictures, they are just not available right now over here, but certainly is a very helpful thing when you are not very sure whether you have to put a stent or just leave it on drug therapy. Then cases like this, when there is multiple lesions during primary PCI, what to do? So in this, generally the idea is to do culprit vessel angioplasty. So what is the culprit here? The culprit is actually the left main. So in here, the left main is ulcerated. It is badly diseased, but there is a lesion in circumflex also, and in distal LAD. So what do? We put a wire through this LAD, left main LAD, and put the circumflex stent first here. Although the culprit is left main. Why? Because if we put a stent here, it may be very difficult sometimes to cross into the circumflex afterwards. So we put two wires, put the distal stent first, and then treat the LAD and the left main. So post stent to LCX, we do a dilatation, we do multiple, these steps, open the LAD and stent from the mid LAD going up to the left main. So this is how we finally treated this case. So basically, we have to make these variations. These are not in trials. We have to make these kind of practical solutions in this patient, as you see, that we have treated everything, but from distal lesions first and then the proximal lesions. And in one go, we have to do everything. So although the trials do not support this, but we have to do in this kind of situation. Now, even more sick patients come to us. Sometimes the patients crash before you take him on the table, cardiac arrest. What do we do in these situations? So what we do is we do a CPR. We take the patient on whatever ionotropic support and look at the ECGs were not too bad earlier, but then he's crashed. His lungs are full with edema, and we do urgent coronary angiography. Patient is already on a balloon pump. And then we decide that if the patient is not improving his blood pressure at all, he's only on a CPR, then we put him on an ECMO system. And this is the ECMO which we have put in this patient and put him on a 4.35 liters port so that now we can do something. So the ECMO is put in the cath lab, as you can see here. And once the ECMO is in position, we start doing the angiography and angioplasty. See, this is how we are doing it. This patient was on cardiac arrest for 40 minutes. And this is the cannula in the right atrium, and there is another cannula in the femoral artery. So we are pushing blood through that. And then we are doing the intervention through the femoral axis from the other side. Very bad disease. We put stents in the circumflex and in the LAD with high pressure dilatations. And you can see multiple inflations, and we were able to get a good result. And after this, what we did was that we thought that since the LV is too bad, we have to give him LV support. So after the intervention, we put a LV support. In this case, from the other side, you can see by an impella. So impella is put in the patient. ECMO is from the right side. Impella is going from the left side. And this is known as ECPella system, where we have put this impella here. And this is the check angio. We are seeing everything is looking good. And this patient was doing very well. His BP came to 160 and everything is fine. But after some time, you can see there is the ECMO from the right side and impella from the left side. And this is how the patient's hemodynamics improved. He is doing fine. But soon after that, he had some ST elevation in 2-3 AVR. So we thought that maybe his RCA is occluded. So we did a radial angiography in the same patient. He was on the table. This is the impella, this is the ECMO. And we did a radial angio. We then thought maybe good idea to do the RCA also. So we opened the RCA also. So much was done for this patient. And this patient was on NORAD infusion to start with. His lactates were 4. He was given all the kind of therapy, but inotropes were completely stopped in 24 hours. And you can see his impella support and ECMO support continuously in the ICU. He was shifted to ICU. His lungs started improving. His urine output was about 100 ml per hour. No inotropes, nothing. And he was doing fine, but his brain functions were not good. And this is the echo. You can see on echo where the impella is. His ejection fraction was not doing so well, but started showing some improvement. And then his neurological status was not good. Pupils were, very slavishly reacting. So we did an NCCT head scan, EEG, and you can see that we put a Swan gans, and his lactates were being measured. His tissue perfusion is good, so everything was fine, and no inotropes. And on ECMO 2.5 liters, MPLA 1.3 liters, and Lasix was given, but urine output is good. See how much it's improving, but everything was fine. But we saw that his BP is very good. You see the monitors, BP, PA pressures, everything is good. So we could maintain his hemodynamics, but of course, over the days he developed some mucus plug, which was removed by bronchoscopy. This is the X-ray. Everything is looking so good. BP is good, PA pressure is good, but his CNS functions did not improve. So then we decided to give it up. But what I'm trying to tell you is that if you maintain the CNS status, then this patient was a live patient and he should have been okay. So this is sometimes we have total occlusions like this. You can see total occlusion of the LAD, and patient has fluctuating blood pressures. So we opened this LAD, and here you see that we're doing OCT, and we found that this is quite a calcified blockage. So in this case, we even did a shock wave. So you can do a shock wave during a presentation of acute MI like this with a calcified agent. You cannot do RUTA, but you can do shock wave. So shock wave was done, and then this patient was having some fluctuation of blood pressure. So we put him on this device, which is a mechanical assist device, which is known as pulse cath or IVAC. This is IVAC. You can see this is the IVAC, which is from the left ventricle. We are injecting blood into the aorta, and the angioplasty is being done at the same time. So this is the post-angioplasty, post-shockwave therapy. We do a OCT again and see that the vessel is fully opened up, and then of course we put a stent. You can see the stent here, and post-stent dilatation, and then proximal segment again dilated, and we got a very good result here with this. See the flow, very good. Shock, this pulse cath is working fine, and once the patient was stable, we removed the pulse cath also, which was put from the opposite side. So this is a comparison of various kind of devices which we use in patients who are very sick, cardiogenic shock, and these are the kind of flows which come with various kind of devices. The costs are variable depending upon which device it is. It may be Impella is so expensive, and IVAC is less expensive. IABP is the cheapest. So I think that will be my last case of multivessel disease in acute MI. How do we deal with this? This is a patient, multivessel disease. Okay, you see lesions in LAD, you see lesions in circumflex, and also you see lesions in, of course, he came with the inferior wall MI. You can see that there is a tight lesion in the RCA, which was immediately treated. But at the same time, we did FFR to LAD. FFR is 0.86, FFR to L6 is 0.84, and the FFR to RCA was bad. So we did one stent, and the patient is discharged in 2 days' time. So that is the approach of treating multivessel disease in acute MI situations. So I think, with this, I will stop here for some discussion if there is some time. Thank you, all of my colleagues there.
Thank you, Dr. Praveen Chandra, for your excellent deliberation. That was a very amazing presentation. Now, learned audience, the session is open to all for question and answer. I will ask our senior chairperson, Professor Sufi Madam, to initiate the discussion and to say few words for us.
Our mic is muted. Professor Sufia Rahman's mic is muted.
Yes. How are you? Very nice
Fine.
to see you. After
Good
a long
evening.
time seeing you. Yeah.
Yeah.
Thank you. Well, I must say that the thanks to the organizer, and both the presenter has presented with a very nice case. Surgical side, we don't understand that much, but all the latest gadgets he has shown, and it's quite nice to see that these are available and it can be used for the patient to have a good and better result. As usual, your intervention in primary PCI, you have done very nicely, and you have explained so nicely that anybody will understand what to do step by step. This is the way to do it, not to rush it, but to have a logical approach. When we have a thrombus, what to do, and when we have a real bad thrombus burden, then what to do. I think you have explained so nicely, and I think it will help all our junior fellows and all of us to see nice cases. The support is very important. Or the critical cases you have done, it is impossible without the EMPALA or ECMO support to do it, and you have demonstrated it so nicely. And I think this is another thing we can look forward to do in our country. Thank you again. I will let others to talk as well. Nice to see both of you. Thank you so much having me. Thank you, Mustafa, Zaman, and your team, and the organizer also. Thank you so much. Okay.
Thank you, madam. This is a very unique session today because usually the cardiologists don't involve the surgeons in this type of webinars, but today I'm seeing that there are very renowned surgeons from Bangladesh. At least there are 4 renowned surgeons I am seeing. So I congratulate them, and now I will give floor to Professor Farooq Ahmed to say something about the surgical approach of the acute complications of myocardial infarction regarding the Dr. Kewal Krishan's talk. Farooq sir, please.
Good evening, and thank you for inviting me to join this program. I'm really happy, and I like to comment that these are the latest developments going on for the management of this bad LV, what we call it. Most of the time these days we are dealing with the bad LVs, and for the management of bad LVs, these gadgets are important. And at the same time, we have to be known to these gadgets. We should start practicing it in Bangladesh. So far, I know, except for IABP, the rest of the gadgets are not used here. So we can start it using here for the better outcome of the patients, and hopefully in near future we'll do it, and then shortly we'll start it doing. Thank you all. Thank you for allowing me to speak. Thank you.
Thank you. Thank you, Farooq sir, for your inspiring words. Now I'm saying that Dr. Shams Munwar from Evercare Hospital, who is a very renowned cardiologist and one of the first in the private sector to do the interventions and doing a lot of cases with complicated cases also. So I am requesting Dr. Shams Munwar to speak something, please. Dr. Shams Munwar, sir.
Probably he was with us.
No, yeah, he's with us, but he's not unmuted. Can you unmute, sir? Shams Munwar, sir? Shams sir, can you unmute yourself? He's with us.
Yeah,
I'm seeing the list.
He's online.
He is offline.
Okay, then we can move to Professor Amal Kumar Choudhury.
Professor Sarabhajan with us or not, Professor?
I'm not seeing him.
Oh, he was with us. Okay.
Next, can I ask Professor
yeah,
Amol too?
Questions.
thank you, Dipal and Dr. Professor Mustafa Zaman for giving me a scope to tell. Thank you for brilliant presentation of Praveen Chandra. Already I met several times with him in different conference. I'm working in the NICBD as a professor of cardiology, intervention cardiology. Thank you, sir, for your brilliant presentation. But the problem is in our country, still we are not using, we have no facility to using the recent circulatory support apparatus like ECMO, right? Like like these things. We are still using in the IABP in the critical case. So though IABP is not study did not show benefit like ECMO, but still we are using when we feel some support from IABP. Thank you, sir, for both of the presentation is very brilliant. Thank you. Thank you, Praveen Chandra, sir, and thank you, organizer.
Thank you, Professor Chaudhary. Now I am requesting Professor Chaudhary Mishkat Ahmed, the very renowned educationist in our country. He is our pride and inspiration. So I will request him to say something about the presentations.
Thank you very much for asking me to say something. I'll be talking on Dr. Praveen's presentation using intracoronary thrombosis, thrombolytic drugs. When the thrombolytic drugs were in table, and in initial days, people used to use intracoronary thrombolytic. And now we can see in few cases when there is heavy blood thrombus in the coronary arteries during intervention, these are also working very well. At one time, there was lack of antiplatelet agent, and we had many cases of intracoronary thrombosis, which culminated into fatal end. But at that time, we didn't have the idea that we could use this thrombolysis. And now we can see that it really works. Thank you very much for showing us all these complicated cases that we may encounter during primary PCI. And as regards Dr. Krishan's cases, those are really fascinating cases. The outcome were excellent and unimaginable. We always think about the transplantation of the heart, and we think about the possible donor, and the long queue for that heart. But now we have substitute for the real heart. We can have the access device which can replace the transplant heart. And there are more and more indication of this assist device. And hopefully someday we'll have all these gadgets in our country. Thank you very much.
Thank you, Professor Chaudhary Mishkat Ahmed. Now I'm seeing that Professor Ekum Reza is with us. So I will request him to give some comments about our presentations.
Please unmute maybe.
Professor Ekum Reza, can you unmute yourself, please? Professor Ekum Reza?
Maybe.
Yes. Thank you very much. Can you hear me?
Yes.
Yeah.
Okay. It's a very great session, I think. Both of the sessions are very interesting and very informative. The first lecture, I don't know why our lecturer somehow gets some problem. I think I don't know what he happened.
Not a problem, actually. I'm sorry.
I'm sorry. I'm a bit anxious because you were a bit coughing. Okay. That's great. That's great. But your lecture is very, very informative, and most of the equipments you are using, we are not familiar with it. We are only using the IABP, not even Impella or some other ECMOs. But we are trying to collect ECMO in our hospital. I'm working in Ibarka Hospital, Dhaka. Hopefully by 2 to 3 months we can arrange ECMO service. Then we can use it in cath lab. So from your lecture, I get a big benefit for those patients who are dealing with the primary PCI. And the next lecture from Praveen Chandra is a brilliant lecture. Every day we are facing this type of cases and we are dealing it. But from my opinion, I use intracoronary thrombolytic or intracoronary antiplatelets. These are not very much effective from my experience. When I use it, usually it does not show any improvement of the thrombus. So most of the cases we have to suck it out, or we have to give a stent, put a stent to smash the thrombus along with the wall behind the stent.
Your mic is muted.
Yeah, your mic is unmuted.
Sorry. Okay. The next lecture from Praveen Chandra. Actually the lot of cases we are facing during the primary PCI. But from my opinion, that during this procedure, intercoronary thrombolytic and intercoronary platelet antiplatelets, these are not that much helpful from my experience. I have used it previously, but without any good result. That's why the usual procedure of doing a suboptimal balloon dilatation followed by a stent implantation. This is the ultimate solution, I think. I don't know, Dr. Praveen Chandra can tell us that the intercoronary thrombolytic and intercoronary antiplatelet, how much it give us the good benefit of during primary PCI. So overall, okay, sir.
Yeah, so no, I just want to add here that 95% it is all stents for primary PCI.
Yeah.
5% patients, when the thrombus is too much, like you saw in the case, then only we have to give some thrombolysis, reduce the thrombus burden, and then put the stent.
Yes, this is you already show it. It works, but in my experience, it does not work that much. That is the main issue. And if the flow is maintained, usually we keep these patients on anticoagulant for 24 or 48 hours. Then again we recheck the angiography, and if there is the thrombus burden reduced, then we can put a stent.
Yes.
So both of the lecture is very great. I think I must thank both the lecturer, and we learned a lot. And hopefully we are trying to get this all types of assist device, but cost is a factor in our country. But still we can use a very limited way. Thank you very much. Thank you, organizer. Thank you asking me to say something. Thank you very much.
Thank you.
Dr. Dipal, can I just ask one thing, please?
Of
I
course,
think
ma'am.
Praveen, can you explain what he asked? Actually, a lot of them have got the same question. What you use and how much you use and how long you wait. If you can tell these three things, I think it will be okay. Because I remember when I was a very young girl, that's an old lady now. First, we in the UK, when they started streptokinase to give intercoronary, I was with Professor Masri and I was doing this intercoronary at that time. I learned it there. So whenever I needed, I could use in this country without any fear, because we started it when it launched in 1987. You can imagine how long ago. So I think their question will be clear. If you can say what you are using, how much you are using, and how long you are waiting. Thank you.
Okay. So very nice point, Dr. Sophia, and you are a pioneer of intervention cardiology from Bangladesh, and we all recognize that, and congratulations to you. So now the thing is that in patients, as Dr. Reza also said, that 95% patients these days, we just load them with dual antiplatelets, put a wire, do a suboptimal dilatation, and put a stent. That is 95%. But some patients have very big thrombus. So in these patients, if as you saw in the last case, that is why I wanted to show you young patients, and many times you just thrombus, no blockage. So in these patients, they are smokers, they are taking some kind of drugs, etc. So in these patients, what we do is, if the flow is okay, we have to maintain flow in these patients. So we put a wire, we give some intracoronary thrombolytic, but this is only in 5% patients, no more. And then wait for about half an hour. If the flow is improving,
that's the thing.
Then we wait for another 24 to 48 hours and then bring them back to the cath lab and check. Many times we see that there's no lesion, no stent to be put. So in a young patient, especially, like that patient was 28 years, 30 years. So you don't want to give a stent if it is not needed. Only treat so we are taking the help of pharmacology. As you already mentioned, you had a good experience from London. So that is all. Otherwise, 95%, it's DAPT, dilatation, and stent.
Thank you, Dr. Praveen Chandra. You have another question from Dr. Musaddek Hussain Sadi of LVAD Hospital. He has asked you that angiojet for thrombosection is now shown to give better results. What is your opinion?
Yeah, so no, we were using these kind of devices like angiojet, thrombectomy, like exciser, like even thrombosuction we were doing, and all these trials which were done for the angiojet, for the exciser, and for the the thrombosuction, all these trials actually failed. So that is why it has been given up almost completely for routine use, unless until there is a very big thrombus which is not being handled. And now angiojet is being, in our hospital, they use only for the peripheral vascular diseases. If there is a large thrombus into the the saphenous artery or the the femoral artery, then only we give it.
Thank you, Dr. Praveen Chandra. Now it's a long time we have not returned to our surgeons colleagues, so I have the privilege to introduce Dr. Lutfur Rahman, who is a very efficient cardiologist in Bangladesh, doing a lot of surgeries, lot of difficult cases in private sector, and who had a cherished desire to start cardiac transplant in Bangladesh. And he's a very dashing surgeon, which we call it. So can we hear something from Dr. Lutfur Rahman?
Yeah, thank you. Really, I was observing today's high-end lecture. I am very thankful to Mustafa Zaman for including me in this session. Really, it is long time also. By this time, I can finish 2-3 surgery also. But I was listening very carefully. I enjoyed today's high-end lecture. First, Dr. Kewal Krishan, really I enjoyed your lecture, your work, your high-level, difficult work basically. Sick heart, sick patient, very difficult to manage. It takes time in the theater, time in the ICU, post-operative, so many things. Full team become tired also, So it's a very difficult task. So I am very glad to know you about your work. You are the registered surgeon in the Asia. So I hope in very near future, I can work with you to develop my center, my hospital, in my country also, if possible. We can work together, we can share our experience, we can contribute something to my country also. Really, I am very impressed.